Great. Thank you, everybody, for joining. We're really excited to get this conversation going. Today we'll be talking about equity in digital mental health, which I'm really happy that it's been a central topic for the Society for Digital Mental Health. I think it's near and dear for all of us on this panel today. And we're really fortunate to have our esteemed guests that have varied experiences in trying to figure out how to integrate equity into digital mental health, particularly in the real world of getting technologies out via companies, startups, and so on. So without further ado, I'll go ahead and introduce our panelists in alphabetical order. So Gaurang Choksi. Gaurang is the founder and CEO of Violet, the first platform dedicated to building health equity via the industry's first provider cultural competence analytics and training platform. Violet's proprietary system for benchmarking cultural competence uses a variety of disparate data about each partner provider, training history, professional experiences, identities, etc., to identify and showcase culturally competent providers. Prior to joining Violet, Gaurang built Oscar Health, a health insurance platform, built from the ground up. He is also a gay man and an immigrant with a deep passion for making healthcare more inclusive for the Medicaid population. Thanks so much for joining us, Gaurang.
Thanks for having me.
All right. Next, we have Jessica Jackson, who's a licensed psychologist with Therapy is for Everyone, psychological and consultation services. Dr. Jackson is an award-winning licensed psychologist and mental health equity advocate. She is the founder of Therapy is for Everyone, psychological and consultation services in Houston. It's a mental health practice providing expert care and mental health startup advisory services. Dr. Jackson is also the co-founder of the nonprofit Communicating Race Fully, focused on teaching youth and their caregivers how to have conversations about race and racism. Her research has focused on reducing barriers to treatment for underserved populations. She is a regular media contributor and serves as an elected member of the American Psychological Association Board for the Advancement of Psychology in the Public Interest, vice chair of Therapists in Tech, and chair of the APA Mental Health Technology Advisory Committee. Thanks for joining us, Dr. Jackson. And then last, we have Carlos Rodarte, co-founder and CEO of Veriteos. Carlos is a mental health advocate and social entrepreneur who believes that structural inequities can be addressed through mindful collective action, innovative business models, and nurturing human connections. His experiences as a first-generation Mexican-American from Los Angeles deeply influence his views on spiritual growth, professional development, and community building. Thank you all for joining us. And as you can see, we have a wide range of experiences. I think the nice thing is folks not only doing work on the one-to-one practice, cultural competence, but we also see some focus on policy, structural inequities, and we really need all of these lenses to address equity. So folks know the structure of this. We'd love it. We want this to be a conversation and bring in questions from the audience. So feel free to please pop in your questions into the Q&A and or chat. I can monitor either of those. And I'll get started maybe with a question to get us going. What frameworks have you used in your work that ensure a bigger focus on equity? So what are some of your guiding principles and some of the things that form your ideas, your thinking that you've seen elsewhere, maybe even that you've developed yourself?
I'm happy to get us started.
Yeah, thanks.
One framework that I've always personally lived by, and one thing I love about this panel is there's so many diverse lived experiences on the panel. one framework that I apply as a founder is making sure that we have diversity of thought and diversity in lived experiences at every level. So at Violet, we're a pretty young company. We have a venture capital funding. We raised about 8.5 million. But what I'm really proud of is when I look at all levels from my board of directors, it's 2 women that started their own venture capital funds, all the way to who's on the team, to really lots of clinical educators that we work with to build our trainings. So for me, one framework that's been really organic, because it's just something that is a shared philosophy across my whole team and me, it's making sure that we have representation at the whole company.
I love that. I think it is important to have representation across multiple facets when we're talking about mental health equity. It's not just for the people that we're serving, however you use the term, if it's consumer, patient, client. For me, one of my frameworks is the definition of mental health equity, behavioral health equity always talks about the right for people to have access and opportunity. No matter what definition you look at, that's what it's talking about. So for me, when I'm working with companies and we're talking about building and scaling, serving, I'm like, well, who doesn't have access? Who would not be able to access that? Because at the very minimum, if they're not accessing it, we're not working toward mental health equity. So if people don't have an opportunity to use their services, whether that's because of cost or language or geographical location, all of those things can be barriers. And I think for me, that's a foundational place to start when we start talking about what we're building. So how do we reduce those things? Then we can get more creative about making sure we're building products and services that feel inclusive, but at the very minimum, if there is already a group that doesn't have access, you are not on the mental health equity track.
Great, thank you, Dr. Jackson. Gaurang, great question. I think there's no shortage of frameworks to apply to health equity and certainly mental health. I think we're all very familiar with them in many ways. I tend to rely on kind of my personal values and how that kind of feeds into the work itself, particularly around deep humility. And I think really thinking about what are the needs of the communities and not assuming that we know the answer, and really surrounding ourselves with people that are living in the community, working in the community, and we're bringing a diverse set of perspectives, certainly as Gaurang, as you mentioned. But I think it's this really interesting dynamic where with deep humility, there's a sense of when to lean in to the work and when to also lean back and let the community itself lead, because it knows what it needs oftentimes, but there's just a lack of resources and tools and support models. So it's in some ways finding that balance between what you don't know, what you're assuming, when to lean in, when to lean back. And I find that often tends to result in bringing a heck of a lot of people into the conversation and making the work more impactful.
Thank you. That's such a great point. I think oftentimes, we think of ourselves as experts, and we are experts in certain things, but we're not experts in all things, right? And I think the people that we're serving or we're working with are experts in, their specific life circumstances, for example. So that's a great point. All right, we have our first question from the audience. Thank you so much, and keep them coming. Oftentimes, even if we bridge the gap in access to care, we still see gaps in actually using care. For example, psychotherapy education to reduce stigma and attitudes towards seeking mental health help may vary across groups or for some groups. Addressing mental health issues is not the priority of their life, even when their service is provided to them for free. Are there some opportunities we can leverage digital mental health tools to address the equity issues and attitudes, stigma, and competing priorities? Yeah, what do you all think about that?
I have a lot of thoughts about this.
Great, let's get it going.
Because I'm going to push here, and this is more a call in for everybody, is how we're defining stigma. This goes back to the definition of mental health equity and access. Stigma is, do they have a bias against it? Is there a problem with it? If I don't know what it is, I've never been introduced to it, is that an access issue or a stigma issue? And I think that often we are building things and we are making assumptions that people know what therapy is, what mental health is, what is mental well-being. I mean, I think about it even now, how many people that I went to college with, or people who see me on social media who reach out and they're like, tell me what to expect in the therapy process. These are not people who don't know how to organize things or work through things, or they have jobs, right? I think we make a lot of assumptions that the people don't want it or that it's not a priority versus they don't know what it is, right? And I think that a part of this is even remembering that more than half of the country doesn't read above a 6th grade reading level. So when you use a word like psychotherapy, that is above a 6th grade reading level. So how are you creating products and services that people can say, yes, I understand what this is, I want to engage? So I challenge people to think about, is it that they don't want it, they don't think it's a priority, or they have stigma, or that they don't have access, no one has ever explained it. The example that I'll give in a quick analogy that I use, if you've heard it before, just please ignore it then. But I think about it like food. We all like to eat food. If I have a friend who's introducing me to a new food, it's not that I don't trust it. It's not like I'm not curious about it, but I'm gonna have questions about it before I taste it. What does it taste like? Why does it look like this? Why does it smell like this? It could be amazing and delicious, but if they don't convince me that this is something I want to try, I'm not going to try it, even if I see them eating it, even if I think that they could be my best friends. So I don't think they're doing something wrong to me, but I don't know what it is. And so once people are like, oh, it's delicious, it's made of this, this, and this is how it's made, then I might be curious and say, let me try that. So when we're talking about leveraging digital mental health, I think a very basic thing is, are you explaining what it is you're offering in terms and ways that people can understand? And are you then creating pathways to access to say, therapy doesn't have to be this many sessions, or what is single session therapy, or all of these different things? Are you explaining it to people so they can say, yes, this is for me, I want to engage with this?
Thank you for that. That's great. Gaurang?
I was going to say, I absolutely love that framework. You know, one thing that my team and I spend a lot of time thinking about is also how much of the onus is on the patient versus the healthcare system. Frankly, all of us in this room, we've all gotten copious amounts of medical bills. And, you know, as a country, we spend $4 trillion a year on healthcare. And so we really believe that it's not all just, the onus isn't just on the patients to advocate for themselves, it's the industry's job. And so a practical example that I think about is, if a patient is going to a primary care provider or an urgent care, and if there is a need for behavioral health care, we want to make sure that the providers are able to speak to the healthcare services that are appropriate and available.
Thank you both. I'll add in, I think questions around access to care often tend to elicit in me a sense that not everything needs to be medicalized right out of the gate. And I think that oftentimes we talk about access to care or, factors that influence utilization, cost, et cetera. But I think there's a more fundamental question of talking about the value of psychotherapy. And certainly there's a place for in treatment of serious mental illness. But I think when we think about the outcomes of people feeling supported, connected, more capable, increased agency in everyday activities, all of those things can come through all sorts of non-clinical mechanisms of community engagement, mental well-being, forms of other forms of healing as well, peer-to-peer. And I think that oftentimes when I hear questions around access to care, I first think about what are the ways in which we're meeting people around the things that they're already doing and culturally are already involved with in terms of talking to their family, engaging around the dinner table in a certain way, and then titrating up when needed and appropriate to a more medicalized form of care when needed, versus starting there and then like working backwards. Because I think it's so much of it is how you present it. I think Dr. Jackson, to your point, I think there's some research that kids won't eat something on their plate until it's presented 15 to 20 times. So it's a certain level of exposure to something before they even try it. So I think there's something to kind of how you frame it up from the beginning that I think really matters.
Thank you all. And I think that, some of the broad issue that seems to come up in this area is sometimes we expect folks to come to us, right? We say, okay, my door's open, come to what I have to offer, right? With a lot of assumptions that this is the best thing, this is the right thing. And, one theme seems to be a meeting in the middle kind of in different ways, right? Whether it's figuring out different ways to engage or figuring out different things. I think we are obviously a lot of us in this conference are kind of therapy trained, and that's kind of our context. But I think it's a helpful reminder, Carlos, to think about some other things and other ways to connect as well. Okay, next question. One of the intimidating parts about being in therapy is how long it takes. It hurts some people's trust in that system when a therapist keeps you for years sometimes. How do these new digital mental health resources make it more reasonable and increase accountability in both clients and therapists to see what is working or not working so they can look for something else? If it's okay, maybe I'll start with Jessica. I think you probably have a little bit more experience kind of in the therapy world, if you don't mind starting us off here.
I don't mind at all. And processing and thinking about the question, I think that the way that we understand therapy, the way that people think about therapy is, I actually think it can be difficult when we say about accountability. And I think that is what has been, what makes mental health so nuanced, is that there are some people who can be in recovery from something like depression or anxiety in 1 session or 2 sessions very quickly, right? Short sessions. And there are some people who it takes a really long time for them to achieve recovery. So I want to be mindful of saying, like, people having a set, there's a one size fits all accountability for everyone, because that's not going to work for mental health. And I think that the way that new digital mental health resources can make it more reasonable is, I see something I'm really excited about is a push that it doesn't have to be therapy. That people are offering things like coaching, people are offering things like modules and courses. It's kind of the reason the name for my business is, like, I do think that therapy is for everyone, and that means an access issue. Everyone should be able to get it. Everyone doesn't need it all of the time. You might have a season where you need it, but you might have a season where you need a coach. You might have a season where actually just learning more about sleep is all you need. And it took you 15 minutes to learn about sleep. You didn't need therapy. So the way I see the new digital mental health resources is that we're showing people more access. It's kind of like allergy medicine. I live in Houston. We're known for allergies. If you have allergies, you take that pill like every day. In Houston, we're taking like 2 things every day. But when I moved here, I learned that some people get the shot because Houston is so prone to allergies that people will get shots for a period of 2 years, and then they don't have to keep taking medication. I didn't know that even existed before. So I was just taking the pill all the time. So that accountability was me learning something new. So not only did my provider offer that, so accountability on their side, but it was also a decision for me. Do I want to do that? Or do I want to keep doing what I know, what I trust, or try something new? So I think that is one of the ways of accountability. It's actually on both sides. And I think with the new tools, it's going to be up to people to try new tools that are presented that are outside of therapy, for them to say, I may not need to be in this forever, but I can learn something really quick that I need. And I think that's my off the top of my head answer for this one.
Thank you. I'm hearing some kind of redefining therapy, right? Thinking about it differently in terms of this one-on-one. And I think that's, in order to fully utilize digital technologies that are available to us, I think we do have to do that, right? It's not just this one-on-one thing anymore. Okay, let's see. Let's go on to the next. Okay, let's see if the next question is, how do equity concerns related to disability factor into any work that you all do? Oftentimes we think about equity, maybe bringing in race, ethnicity, sexual minority status, and I think increasingly we're becoming more aware of kind of disability and how that factors into the equation.
I'm happy to start.
Yeah.
The reason we started Violet in the first place was a good chunk of my team and myself built a health plan called Oscar for many years. And one of the things we wanted to do building a health plan was build culturally responsive networks. And really what we were finding was quite often people would call in and say, you know, I want an LGBT physician, I want a Black therapist, I want a veteran psychiatrist and more. And oftentimes we didn't have the data on the diversity of the clinicians, nor did we really know how inclusive the facilities were. So maybe the clinician was inclusive, but the facility wasn't. When we think specifically about disability, we've often heard very similar concerns, which is somebody could end up at a facility, but if the facility isn't accessible, or if they're not prioritizing accessibility end to end, that facility, even if the provider is inclusive, they may not be able to actually serve every patient they want to serve. So at Violet, one of the things we've really done, and we're seeing quite a few of our health plan partners prioritize this, it's really data collection from the onset. So when we work with partners, we're always not just learning about the diversity of the clinicians and the team, but also looking at the skill set and the inclusivity, and then how accessible is every single facility too.
That's great. Thanks, Gaurang. I might chime in a little bit. I've built a number of mental health care companies at this point. The latest one, Veriteos. This is a large part of what we do is we help understand the community's needs. So we'll do kind of geospatial analytics. We'll bring in, private clinical data, public health data sources, CDC surveys, a host of things to really get a sense of what are the needs of the community. And then we match that up to the types of providers that are providing care in kind of that area. And then say, do we have general alignment on the types of providers and how the care model is organized at health centers to actually fit that need? Oftentimes, one of the things that we've encountered and one of the biggest lessons learned is that, when you do care navigation for mental health care resources in the community, oftentimes you find people in the community through community-based organizations, for example, and then you guide people to a care site, whether it's virtual or not. But oftentimes there hasn't been enough upfront work to quantify the capacity of those sites to provide culturally responsive care. So there may be wait times that are an issue. So I think, really finding that kind of balance between how do you help meet a need while ensuring that when people are referred somewhere that they're actually going to be treated appropriately. And I think that's a very difficult thing to do. But I think that's a function of kind of the disability and function of access, but also more broadly, how do you think about the provider workforce itself?
Yeah, I will double down on Carlos's focus on the access and the accessibility. It's one thing to be able to refer someone, but if they're not able to support that, the referral matters a lot less. It doesn't help them, right? And so for me, I think equity concerns related to disability factor into all the work. It goes back to an access issue. It's for, if we think about brick and mortar, if you are saying that I serve everyone, I treat everyone, and someone cannot get through the door to your office, then you don't serve and treat everyone. Really simple, right? And so when working with people, in an ideal world, I would love for it to look like, I don't know if any of you all watch Bridgerton, but this season, they're using sign language throughout the show. And it's not something that's like everything is a part of it, but it's included. And I think in an ideal world, that's how it would be. It's like you see all of these differences and it doesn't feel like anything is like emphasized. It's just a natural part of it that people have the option for this. And I loved seeing that they were using sign language because I'm like, and it flowed. It wasn't like, oh, we only have one scene where it's one thing happening. It was just like a part of the background and people were doing different things. And I'm like, that's ideally how mental health would look. There's a buffet. People can say, this works for me, this doesn't, but I don't feel singled out, or I don't feel like the emphasis is on it so much, I have to highlight it because I might be coming in for concerns that are unrelated to my disability, and I want that option as well. And so I think when people are working together, it becomes, how do we make sure that people have access? And that goes back to that fundamental thing I said at the beginning. If there's someone who cannot access your services, if you are offering telehealth services, but somebody who is deaf cannot participate because you don't have the right equipment, you're not offering services for everyone. If you don't offer things that are larger font type on your paperwork or different things like that, you're not offering services for everyone. And I think that people have to acknowledge that piece first in order to then change it. And that's one of the things I encourage companies to be mindful of, to say we're not for everyone, to be clear about that. So you don't, to Carlos's point, get people who are coming in and then saying, this is not for me. Like, that's really discouraging for people once they sign up and they go through everything and then you don't have anything to be able to help them.
Yeah, those are great points. And it reminds me of another issue that often comes up in this work. And I'm curious what you all think. People often want to address equity and target specific populations and be culturally responsive. But then they also want their products or tools or interventions to be open to everybody, right? And it's kind of, we often we want it all to exist at the same time. And I'm curious what you all think. Given the fact that I've heard that so many times, how would you answer that question in terms of personalizing for specific groups? Let's say, this example of I think disability is an important one versus making things available to everybody and being generalizable.
I'm a big believer in you have to be honest and candid with yourself, right? We serve quite a few digital health partners, quite a few health systems and more. And if you feel that you don't have the representation you need on your team, or you haven't been able to make the investments in upskilling the team, or you don't have translation services stood up or more, you need to be honest and accept that, trying to serve everybody is a recipe for disaster. And I loved what Dr. Jackson said around it can cause a lot of harm if you try and serve everyone at once when you're not ready. So I'm a big believer in just being candid and realistic around what are the communities you can serve from the onset, and what are the communities you need to grow as an organization to be able to serve in the future.
I think there's, thank you, Gaurang. I think there's an element here of, from a digital mental health perspective, and like digital health companies and people that are using virtual models. I think there's like the technology model, there's like the product itself that can be kind of, scale ready, from that perspective. But I think that for some populations, that last mile, so to speak, is one where the human connection really matters. And I think really bringing in kind of this human component, goes a long way. And I think that a point that I'll make here is that oftentimes the way to customize or personalize is by just, really embedding empathy into the process. And one doesn't have to look exactly like me or have my lived experience exactly to know some of the issues that I'm going through or that some other group is going through. And I find that really good therapists or really good platforms have a way of saying, hey, this is part of a broader immigration story that impacts a number of ethnicities, for example, in a number of countries, in a number of languages. So I think oftentimes I find that from a tech product stack perspective, some of those can scale, but that sort of last mile, that experiential part is one that can, get a lot more investment in terms of modalities, whether it's, fully automated, chatbot style, which I'm not always the biggest fan of for all cases, to those that are more personalized and human oriented.
I think this is a larger issue that the digital mental health community will face. I think it's going to actually be reimbursement. I think that companies do well when they offer multiple options. But what makes it difficult to personalize is you can't get reimbursed all the time for that, right? So if I want to say generalizable, like we treat, I'll just use anxiety. The personal piece would be, we have modules for anxiety, we have therapy for anxiety, we have coaching for anxiety, we have peer-to-peer for anxiety, we have all these options so that people can figure out what works for them. What makes that difficult is then people will say, but the only one we're really getting reimbursed and paid for is therapy. So it's difficult for us to offer these options because we can't make any money on it. Or even what therapy looks like. I have worked in places where I have had the space because of how we bill. Well, we can do just a 20-minute session because that's all that person can tolerate at the time. However, in something like digital health, and because most of these companies are trying to get reimbursed or funding, if I submit for 20 minutes, that's no money. right? But that might be what that person needed. Maybe they needed 20 minutes of therapy, and then they're going to go back and work through a module, and later their coach is going to check in. That is the best thing for them and how they can hit recovery quickest. And also offers options if they have a different able-bodied status, if they have different language needs. Maybe it's too much to just do English for more than 20 minutes and different things, but they can't get the funding. And I think that's a much larger issue, is how do we start to value all of these different options for people so people can have all the options they need and it is reimbursed or paid for, so that people can actually get what they need and not just what is covered.
Great points. Thank you all. Our next question is a bit of a follow-up, I think, on something that that Jessica brought up. How can we help people decide whether they should engage in therapy versus coaching versus modules, et cetera? How can we help people decide which tools will work best for them and their current needs?
I'll tell you, we got to move past the PHQ-9. That's one thing. Everybody is offering screeners and short screeners, short assessments. That doesn't actually decide if you need therapy versus coaching versus modules, but a lot of people are. I think it goes actually back to points that have been made by everybody here. You do still need that human element. And honestly, a lot of what we're seeing in digital mental health has been done in brick and mortar. They're just making it virtual, which increases access. But I've worked in a clinic where there was a whole team, their whole job was to do intakes and then determine which clinician, because everyone had a specialty it goes to, and they would be like 20 minutes. And because there was a triage system, somebody can meet with them and they say, you actually don't need therapy right away. We're going to send you the link to be able to go through some modules and see if that helps you first, or we're going to refer you to this other thing. So I think one of it is being able to meet with someone that can very quickly at a high level say, here's what I'm hearing, here's what might be useful. And then I think this goes back to the education part, letting people know that they have options. Here's what a module is, here's what coaching is exactly, here's how it can help you. And then it's a collaborative decision. So when someone comes into your tool, for example, and they get triage, because I do think that those human elements can also be optimized for efficiency using technology, whether it's a brief questionnaire that's not just about their symptoms. I think that's all that people are doing now, but it's like, what is your environment? What is your current home status? What is your language preference? We need a little bit more information to say if you're going to be a good fit for a module or for therapy or for coaching. And I think that once we can figure that out, then we can help people decide which one they should engage in, or all three, quite frankly. I think you can use all of them. But I think it's going to be a collaboration, and I think technology is set for that, to optimize for that efficiency. We just need people to, again, I think it goes back to reimbursement. People are offering the PHQ-9 and the GAD-7 because they can get reimbursed for it. There are CPT codes for it. And also because people think it takes the least amount of time. And I'm like, how do we add a few extra questions, right? If somebody has 9 other people in their household, therapy might not be the best option for them. They don't actually have the space for that. So if we don't have that information, I might refer you to therapy and you can't actually leverage it because you're trying to find a place to be in a quiet space. So adding some additional questions to some of the screeners that we're using.
Great, thank you for that. We're getting some great questions coming in, so I'm going to try to get as many of them as we can in the next 15 minutes. The next one looks like I'm going to summarize it a bit, but one key question is about kind of access via insurance. So one concern is I'm afraid digital mental health is going to end up like services we have for autism. If my patient has private insurance, then they will have access. If not, then access is an issue. So how do you see kind of access going forward in terms of whether people will have access to digital platforms? And I might add, could we also see the reverse potentially, where maybe people with lower quality insurance have only access to some basic digital tools, and people with better insurance have access to maybe in-person only? Let's think about access and payers and where you see that going forward.
I'm happy to kick off. At Violet, we have the luxury of working with quite a few health plans, and predominantly they're Medicaid plans. What we're seeing in the market is actually because departments of health at numerous states, at CMS as well, there's been a huge push for more integrated care across behavioral health and physical health. And there's been a huge push for building health equity. We are seeing some really interesting policy come to market. But one thing I can share is one of our plan partners, they're actually reimbursing facilities and providers more if they're certified inclusive. Meaning if that health plan is seeing that the facility and the provider has gone out of their way to both build a diverse team, train everybody, make sure that people actually have time to complete education to learn to be more inclusive, we're seeing health plans actually allocate reimbursement rates or enhanced reimbursement rates for inclusive care. So for me, maybe I'm not even overly optimistic, but I'm excited by just the movement we're seeing on the Medicaid side specifically. For digital health, I share that concern, to be perfectly candid, that we don't want all innovation specifically for like modules and more to be on the commercial side. But the partners that we have, overwhelmingly, I'm hearing that they all genuinely want to serve everybody, but they acknowledge that it's going to take time for them to be able to serve Medicaid and Medicare communities or populations.
I'll really quickly add to this, a call in for all the clinicians who are listening to this. Excellent opportunity. Every year, there's the opportunity to comment on what CMS is going to reimburse for things like digital therapeutics and things like that. And I can't tell you the number of times I hear from other clinicians that like, I don't use technology, that's not for me. And I'm like, actually, this will impact you, right? And people don't recognize. So I know we've talked a lot about education for patients and consumers. There also needs to be education for a lot of providers about how digital tools can be used in their practice, how they can be helpful so that they can advocate for these things to get reimbursed through CMS and public health insurance. People don't advocate for things they don't know. So a call in for people here to make sure you're including providers and thinking about that. We're talking to payers and how they can also get involved and write comments and advocate for new CPT codes and things like that.
There's also a real practical lens, I think, around just broader reimbursement rates across mental health, whether it's digital or not. And I think that oftentimes when you think about kind of adding coverage benefits, behavioral health is a carve out. And, it's one of those things that often, is cut in terms of rates, or it's not, reimbursed as highly as it should. And this causes a lot of health centers in the community setting, for example, if we're kind of taking a health equity mindset, that providers are too expensive and the rates are too low and they're operating in the red is often what we see. And I think that part of the broader issue, and I think this is really a call to action for everyone in mental health, is to really quantify what the value of an outcome is more broadly than just, to your point, Dr. Jackson, the HQ9, but, what is the, full clinical value and impact of now managing your hypertension or your diabetes, and what is the life impact in terms of employment, what's societal impact, and tying it, across these layers of value to say like, hey, the reimbursement is not, it shouldn't just be $160 an hour or 140 or 130. Actually, it should be a little bit higher to at least cover the cost. So I think that there's a broader area around fuzziness where behavioral health doesn't have the hardest metrics clinically. A lot of it is subjective, but we can get more objective hard data on the outcome that comes out of positive therapy. I think that could be a really interesting data input into the broader process.
Great. Thank you all so much for that. So the next question, I think it's an interesting one. It's one that many of us at various stages in our career struggle with in terms of attention. And I think it's key with digital mental health, and it's this issue of kind of for-profit, right? And business models and so on. And I think, some folks are concerned, how can you have for-profit models when we're trying to increase equity? One example is a trade-off between maybe not being able to access something due to cost, or maybe having to give up data as a result, instead of paying for it with your data versus with your money. So how can equity be increased in a for-profit environment?
I'm happy to start. Violet is a for-profit company. We are venture capital funded. The way I think about having impact at scale while making money is you have to spend a lot of time aligning incentives. And it frankly kind of comes down to honesty and integrity with what are you actually doing? What communities are you serving? And are you able to admit that you're not ready to serve them yet? At Violet, we don't deliver healthcare. We're an infrastructure company. So we educate partners and we use data to help health plans really build and scale inclusive networks. But an example I can share is in California last year, they passed a law saying each of the 26 Medicaid plans has to sponsor cultural competence training and track that data. What we found was all 26 of the plans, they didn't have the training, and tracking across each plan was really, really hard. And on the clinician side, it was really onerous if each plan was going to give them 1 hour of training to do that each of the plans built. And so at Violet, the value we created is we went in and we actually brought everyone around the same table, and we let them know that with our technology, not only do we have the training that's quality, but we can actually share that data so that everybody could actually they could gain benefit from that. So the providers had quality education, the health plans had data that allowed them to do the reporting, and the Department of Healthcare in California got to see across the board that their initiative they championed was actually completed or they're making progress. So a long way of saying, I think about it as really just value alignment from the start.
$1 million question here. I don't know. I don't know that I have an answer. So I can give a thought on it. That from even a personal lens, I've had this conversation. The NIH has a program they're doing right now. I cannot think of the title of it. I think it's something about all of us. So basically they're trying to increase representation in clinical trials and all of these things. And I have a family member who has cancer who decided to participate in it because their thing is, on the flip side, they cannot complain about not getting the treatment they wanted when there isn't data based on people who look like them. And so I think that is a fine line that we have, especially in digital mental health. Unfortunately, we do live in a world that is for profit. And it is really difficult to create things when we don't have data to say, this is what the needs are. This is what we need to be building to and for. And so I think it's a personal choice that people have to think about is we have to some point, give a little bit of our data to create equity. To me, it's kind of like working at a job. When you work at your job, they own all your intellectual property. You do it because you get a paycheck, which helps you to do all the other things. You don't necessarily want them to have all the ways you created templates and emails and everything else, but there's an end to the means, right? There's a means to the end. So I kind of see it in the same way. I don't think it's a perfect answer, but I do think it's difficult to build for marginalized and underserved communities if we're not being able to share data for them to be able to build it.
Great point. I know we're coming up on time. I'll be quick here. I think there's a real issue here when you start thinking about the capitalistic system that we're in and kind of where the need is and where the business model resides. And oftentimes those two things do not overlap. And I think that when we start thinking about the structural issues around access or just mental well-being or mental fitness, however we want to call it, the broader issue is I think that there seems to be, at least in the US, a real lack of accountability by the public health ecosystem and our public health institutions to be sort of the buyers, of, call it, mental health outcomes. And oftentimes it gets relegated to the health systems or the plans themselves. But I think it's one that I've given a lot of thought to. And my company, we specifically do not work with health plans for that reason. We have a direct-to-provider revenue model, even though it means that we charge a heck of a lot less, but we're going to where the need is, not necessarily where the revenue model exists to date. So I think we have to just be flexible in our pricing and the way that we structure our company in that sense. But we don't want to be only relegated to the dollars available in kind of the plan world.
Thank you. I think you're highlighting an important tension, right, in terms of I think also how to get things out into the world. I've turned around to see the value in a business plan and actually getting even whatever good product. You can build something good, but it has to figure out a way to get out there. But it is a tension. So I think this will be our last question, kind of the big one. How would you see to this point digital mental health has been around for at least a decade to some in different ways. How do you see to this point whether it has increased or decreased disparities, or maybe somewhere in the middle? Where do you all stand on that? Where have we been, and where are we going with respect to disparities in access overall?
I can share a quick thought. I think we're still in the middle. I think that we have increased some access for people depending on where they are. I think we forget how many people still don't have access to technology. So we're still leaving people behind. People who don't have a cell phone that has a data plan per se, or they can't download these different things, or they don't have video. So I think when we only focus on technology, there's still a group of people that are being left behind in this way. So to me, it's kind of balanced out. I think we've increased access for some people, and we have not improved access at all. And I encourage people to be mindful when you're building something. Are you increasing access? Are you giving more people access? Or are you giving more people options as you're building? Because we are at risk of increasing the disparity and leaving a group of people further and further behind when we're only focused on options.
I fully agree with you, Dr. Jackson. When I think about the progress that we've made across the whole digital health ecosystem, I think we've made a lot of progress, but there's still a long way to go. Whether it's additional reimbursement models, more integrated care, making it easier to move through whether it's synchronous or asynchronous or module, what is the care that's delivered with what capacity? We still have a pretty long journey ahead, which frankly, I'm excited for as an optimist.
I think that the one thing that I'll add here is specifically to digital mental health. And, I was very early in kind of the digital therapeutics movement, and I've been integral in that community for some time, less so more recently. But I think one thing that I reflect on is often, it seems like it's the companies and the for-profit companies, VC-backed companies that are really the ones that are trying to communicate the value of digital mental health. What I'm not seeing is a groundswell and bottom-up kind of, yelling from the mountaintops by the people who have experienced the benefit, and giving, the recipients of the therapy kind of a microphone to really voice why this was so much better. Just in talking to friends and family members, I hear it all the time. I love the idea that I didn't have to take a pill today. So it's sort of like, there's such fear in taking a pill, but if you have a digital option, like, people are raving about it. But those stories, that movement is not one that I'm hearing. So I think there's a little bit of how do we learn from the political process, into sort of creating kind of word of mouth marketing that really kind of uplifts everything.
Thank you all so much for sharing your valuable insights on kind of where we've been, where we are, and where we need to go. I think we've all learned quite a bit. Thank you to all the attendees for joining, and enjoy the rest of the conference.